but this is just a neat case. So we've talked a lot about scimitar and all the neat variations that come along with it. And this is not only is this one a beautiful radiograph, but it's got some cool findings. So there's the scimitar vein, the hypoplastic right lung, not terribly hypoplastic looking. And then there's a little bit of shift to the right, but not a lot. But the CT is, I think, where the interesting finding is. And first thing is there's a left SEC, which I don't recall having seen with a scimitar. So that is kind of cool. The next thing we always talk about are, there's anomalous branching. So it looks like these may be two hyperarterial bronchi. Not 100% sure. I'll make a coronal, but they look like hyperarterial bronchi. And then you can see there's the upper lobe only has a single segment. And then what's really kind of cool is that I think this would qualify, and I'll make a coronal, but I think this is a real left tracheal bronchus. It just kind of gets sandwiched in there. And then there's what you see, just the little basal segment. So the left lung isn't normal either. And then we see there's no pulmonary veins on the right draining into the left atrium. So the entire right lung goes through this big scimitar vein into the the junction of the IVC, just below the junction of the IVC with the right atrium. So let me make a coronal of this and we'll take a look at those airways because they're kind of cool. You look at this here, and I think that would qualify as a true tracheal bronchus. And there's a sliver of it. I think it's being compressed in here, and you can actually see the distal air trapping up there. So there's probably a little air getting through. So that's kind of cool. So this kind of like mirror image airways, and they both are hyperarterial. There's the big scimitar vein. I didn't see any diaphragmatic issues. I looked for systemic arterial supply. I didn't get any history on this. And then this is, you can see that bronchiectasis in that left upper lobe, I think just because it's a post-obstructive phenomenon.
Very cool.
Yeah, so this goes in our extra cool scimitar cases.
Is there only one pulmonary vein in the left lung draining?
Yes, it drains the entire lung and it drains in the scimitar vein. There, as far as I could tell, I could not find a single vein draining into the left atrium.
Just look at the, no, just a common vein on the left side.
Oh, I'm sorry.
Veins drain to the left atrium.
The other left. Yes, correct. Yeah, there's a single sort of big vein draining in there. There's the superior vein. I think there is a superior vein coming around here that dips in right there, but it's pretty small.
Oh,
there's a large vein draining the left lung. So
yeah.
But that was kind of cool. I think it qualifies as a real left tracheal bronchus. I've never seen one. All right, this was a incidental finding. This was one of these. I think I remember the history was. I think the patient presented with a brain mass or something, and it was the search and destroy for a malignancy before, just as part of the workup. And this was a completely incidental finding, but definitely on the larger side of broncholiths I've seen. And you can see it protruding into the bronchus intermedius there. And there's you can see the calcification. There's more calcifications in the other areas, but just a classic calcified lymph node from histoplasmosis. There was no distal obstruction or anything. I couldn't find any older imaging to see if there had been previous infection or anything, but I'll show on the axial right there. So I don't know what they're going to do about it, if anything at all. But it could potentially do a bronchoscopy, but it can be kind of difficult to deal with. Usually can't remove the whole thing. Sometimes they can laser them if they're causing symptoms, but given her brain issues, potentially if there's going to be any compromise post-op or things like that, potential for post-obstructive an aspiration with some post-obstructive or just a hospital-acquired infection. That's one of the bigger broncholiths I've seen. I can't remember
classifications in this one.
Oh, spleen! I knew you were going to ask me that.
My second favorite.
Yes. No, but around here that's still histo. There's the primary site. We don't see the. I see splenic calcifications a lot, but I'm trying to think about what percent have a large number of them. I don't know, maybe 5 or 10%. But yeah, it's an important point because you don't typically see that with other granulomatous infections. I can't remember if I showed this case. I know we've talked about this before, and we actually included this in one of our posters we did for the ECR about ablative therapies. But this was a nice example of some left atrial calcifications that can develop after RF ablation right there. And you see it right near the vein. This one's right by the Coumadin Ridge, as it's called sometimes, which is kind of a silly name, but that's what they call it. But you can see these nice calcifications along there, and they can happen years. And I don't know exactly how long this was, but it was some time. So one of the causes of left atrial calcification is just from old ablative therapy. And then this final case is, we don't have a chest radiograph, unfortunately, but this is a middle-aged female who had hyperparathyroidism from an adenoma that was treated, and had developed this humerus fracture there. I just threw that in there, and you can see the funny-looking bone there. But it's a really nice example of so-called brown tumors. You can see all these expansile lucent lesions in the humeral heads and the scapula. Almost looks like multiple myeloma, and you can see the fracture there, and there's one in the rib there. And I had a clinician was asking me, how do you tell the difference between this and myeloma? And it's kind of hard, to be honest. Typically with the so-called brown tumors is there's not an extra osseous extension. I mean, although myeloma doesn't have to, I think they look very similar otherwise. And then what's really cool is the medullary nephrocalcinosis to go along with the hyperparathyroidism. All right. So that's what I have.
So Jeff, the hyperparathyroidism was secondary to renal disease then?
No, it was primary.
I see.
It was from an adenoma. Yeah, and my understanding, at least in my experience as well, is with secondary, the brown tumors seem to be very uncommon. They're not that common to begin with, but the cases I've seen that I recall have almost always been primary.
Got it.
All right.
I can go, Jeff.
All right. There we go. Now I figured it out.
All right, eye test. So this is a patient who has back pain. This is back in a couple years ago, and it's kind of midline back pain. So I will, this was at an outside hospital and called normal, and I think that 99 times out of 10 or out of 100, I think I'd call it normal. You guys see anything?
Something below the corona.
Yeah, it's right here. There's very subtle, loss or obscuration of that azygoesophageal recess in that interface there. This is the spine radiograph done at the same time. I think this is one that I'll just go straight to the radiograph. So the next radiograph, this is another one. I think, David, is your observation. You can see there's more fullness. This is a year later, also called normal at the outside, still has back pain. It's hard to say if there's really, would you call anything here? Maybe that, but again, there's so much overlapping stuff. It's just inferior to the left pulmonary artery. And then finally got called, obviously detected here. And at this point, unfortunately, there's this and this, and you can see that now you have this large mass splaying. It's kind of splaying the bronchi and filling in that entire subcarinal space and visible everywhere. So this is the CT that was done after that. It's kind of interesting that it's eating into that vertebral body there. And this turned out to be some sort of just undifferentiated high-grade sarcoma. So they were unable to further characterize, and again, at this point, it doesn't really matter other than treatment and prognosis. But I think a good eye test on serial radiographs. Howard, what do you think?
Oh, that's hard, isn't it? That's way hard.
Yeah.
No, that's way hard. No, that's too hard.
Agreed. This is one that's, I think, the good example of being biased by the history. This is a patient who's 54 and he has bilateral deep brain stimulators. He has Parkinson's disease. And they did an echocardiogram. He's had some respiratory and issues and whatnot. But on the echo, they questioned whether there was a mass adjacent to the inferior vena cava. And I don't have the exact way it was worded, but that prompted evaluation with a gated CT. And so with that, I think pretest bias in mind, this was seen, and it does look a little discrete here and a little bulging there, and was suspected to be a mass based on this, and it was actually somehow got referred to our interventional pulmonologist. You know, no way he's going to be able to do anything via bronchoscopy, which was kind of funny. But anyway, I looked at this, and my first question was what mass, because I guess I wasn't biased by the history. And you can see here, even when you reconstruct it, that it's very heterogeneous, and there's some little streaks. Some of it may be actual streak artifact. The rest of it just looks like contrast. And of course, it's continuous with the inflow of the IVC. And so I thought this was just going to be just like a little bit of bowing of the interatrial septum, but probably just inflow of unopacified blood. So kind of a transient interruption and a little bit of smoke phenomenon as a result. What do you guys think? Mass or no mass?
You see the axial one more time?
Sure. I'll put them side by side. Because this,
I think there's something discrete there.
Yeah, something's pushing on the septum.
Yeah, it looks real.
yeah. So, and this is kind of, we were split. I was, looking at, especially in the coronal plane, I thought this was just going to be some sort of inflow and smoke. And we repeated. He couldn't get an MR because of his deep brain stimulators. And you can see on the repeat, it's just inflow of now opacified blood on a delayed phase. So no mass. And I think it just happened to be, I don't know why it's so much more discrete and bulging here. And going back to the echo, it was not even in this area that they were actually worried about anything. But it was more, I think it was just a little bit of fat or something anterior. We never figured out what it was they were really talking about. But mass like smoke, and I think there may be just a little bit of atrial septal aneurysm, but
Okay.
not a tumor there.
This business teaches humility.
I think in this one, just it's just thinking about what could be here that's normal, and of course just the inflow of the blood straight up there from the IVC, even though it is interesting how it deviates the septum there. And then this is a good one that one of my residents showed me. This is a patient who had a head and neck CT. He was found down, had chest pain, and they activated the STEMI, the code STEMI. So they were doing this just to make sure he wasn't having a stroke before they went straight to the cath lab, or that he had fallen and injured his cervical spine. And the resident correctly saw all of this and was worried about blood in the mediastinum, and specifically worried about the aorta because there was a little bit of higher attenuation in the wall. By the time they read this, the patient was interestingly already in the cath lab, and they, not surprisingly, did not find any sort of coronary pathology. I don't know if they did an arch angiogram or not, but you can see on the subsequent radiograph before doing, or around the time they did the CT, that sure enough, looks like there's some widening of the superior mediastinum, maybe a little bit of tracheal deviation here, certainly losing the aortic contours and a little bit of the aortic interface, and maybe a little bit of of an apical cap. So not really a high level trauma. And as you'll see on the CT that they eventually did, that this is all just a dissection. It's a type A dissection. There is hemopericardium, and there's some shared sheath hematoma, I think, as well. It's kind of curious, that the tear is here. It's kind of an unusual location, and I would have been worried that they might even get into that when they were doing the cath. But still, the patient has since gone to surgery and had this repaired. But it's kind of, you guys agree that it's a little bit of an odd location for a type A dissection that we typically see.
Yeah, it may be that is the tear is the entry site, and then we have retrograde propagation of the pathology into the ascending aorta. So it's a retrograde pathologic process that started in the arch, and then the rest of the pathology went retrograde to involve the ascending aorta, that kind of sequence.
And I think even here, you know, they were worried about the aorta, but I think you can even tease out a little bit of the wall on that other study too, even though it's non-con. Just like you can see it on the non-con of the chest, you can see the displaced intima here. But presentation of a type A dissection or type A dissection presenting with symptoms of STEMI.
Do you know that when they took the patient to surgery, whether they did something to close the communication between the two lumens in the aortic arch? For example, do your surgeons ever do a frozen elephant trunk procedure or an equivalent to close that rather big communication?
I will look and see if the op report is up. This just came in, so when I downloaded this, there was no final op report, but when somebody else is showing case, I'll look right now. And I'll tell you, because that's a good question, Howard, because it's probably not just the typical hemiarch repairs, given where this big tear is.
Yeah.
So,
and
I'll take a look.
Mediastinal blood, and perhaps even retrograde extension of that along the bronchoarterial connective tissue sheath?
Well, there's definitely there's definitely some shared sheath along the pulmonary arteries, I think. The pulmonary arteries look a little thick, and it's not really high attenuation, but it's definitely, there's definitely a little bit there. And then going out further, like the fluid cups that you've nicely shown before, I don't know. Now, there is a little bit, he's got some airways issues as well. Looks like he may have aspirated.
Boy, that's pretty scary looking.
Yeah, so I'll look at that right now. Jeff, that's it for me, and I'll get back to you.
All right. Who's next?
I have only one case this week that I can show.
Okay, there you go.
This is a case that was shared with me from the abdominal section, and it actually goes back to last year. And this was an incidental finding or an unanticipated finding on a scan in a patient with as you can see here, a tumor in the abdomen. So that's a neuroendocrine tumor. So what was particularly evident was this, and this is the part of the abdominal CT. So we have this abnormality in the apical portion of left ventricle. And then we can see, and I'll show you the non-contrast, if I can find that here. Nope, that's not what I want to show you. I'll show you the contrast from 2008. And I want to show you the non-contrast from now. So let me unsync those to show you that we have a nice example of lymphomatous metaplasia in relation to the apical portion and interventricular septum, which is new from 2008, consistent with a myocardial infarction. So that is that finding. And then let me go back to that one, and one can see that there. So here is the arterial phase, and of course it's abdominal CT, so they continued. And we will see now that that is a pseudoclot because it fills in on the portovenous phase. So a really nice example of basically a smoke phenomenon of slow flow stasis in the arterial phase that completely fills in a little bit later. And I think the time difference between these two wasn't that much, but a minute or so, seems like. But fills in. So pseudothrombus, a flow phenomenon, a smoke phenomenon right there.
I love it.
That's
I would have called that a thrombus for
yeah, I
sure.
would
If I
too. That's really
The clot thickens.
That's a really good one.
or the thrombus embolized.
yeah, isn't
Wow,
that a nice one?
that's a big difference in density. That's quite a
Yeah. Now, I don't know if this means anything, but you could say, well, the interface, knowing exactly what it is, you could say, well, the interface is a little fuzzy here. It's not that sharp, but of course, no, it's like a thrombus. But
Howard,
it's just
what were the Hounsfield units on that one?
right over here
Yeah.
in that area. Down there, we can load that in here in this area. Interesting, that is 74 of a mean. Let's see. So making that a bit smaller, it is 56.
Yeah, this is a really good case, Howard, because oftentimes we show cases where we're too early and then you uncover the thrombus when you wait for the delay phase, but this is the opposite.
Yeah,
It's really a good case.
it is interesting that it's up in the 50s and 60s, isn't it?
Which I think supports the smokiness, right?
Yeah, well, and it's just the fact that you see the fatty metaplasia in the ventricle just tells you that it's not moving at all. So that's really stagnant blood.
Yeah, at least transiently, it's not moving and it's just then fills in that whole area. Nice case, huh? All right, that's mine for this week, Jeff.
all right. Thanks. That's wow. I'm have to go look at that one closer. All right, Peter or David.
Not me
I can
this
go.
week.
All right.
I have two quick ones.
All right. I'll make you in charge here. There you go.
Thanks. So both of these were shared to me by Arthur Stillman. Start with. So this is a patient in her mid-60s. The only medical history is hypertension. And she was referred to our vascular surgeon with this finding, which is a small type A intramural hematoma. And so he elected to medically manage it because it was relatively small. And she came back a month later with the CT, which looks good. So looks like in 1 month that intramural hematoma almost resolved essentially. It's really not visible on this CT, and I can show the arterial phase as well. But unfortunately, it's like 7 or 8 days after that, she developed acute onset back pain, and she was imaged again. And I'll show the non-con. So this is several days later after that resolved IMH. Looks like she has a new acute aortic syndrome. There's a new intramural hematoma here, and it's involving the ascending and descending aorta. Here's the arterial phase. So probably this one is easier to see on the non-contrast. And then
She's just severely hypertensive, or what's the
only thing from the history I saw was hypertension. Yeah, and I
Yeah.
can't tell you the exact pressures that she was having. So
oh,
this, and then so the most interesting thing is then a few days after that recurred, she was scanned again. And this is her next non-contrast, and it looks a little bit strange there. Let's take a look with the contrast. So this is just 3 or 4 days after the last scan, she has this abnormality. So this is a complicated type A intramural hematoma, which is complicated by a ulcer-like projection in the ascending aorta. And it's just kind of interesting how fast this developed. And then our surgeon also he repaired the ascending aorta, and these are some intraoperative photographs. This is the ascending aorta, the root, right above the root where that ulceration is. This is just a photograph of the arch. But here's the photograph of the intramural hematoma separation between the intima, media, and adventitia.
Were there any defects in the intima noted?
Yeah, this looks like the defect in the intima right there.
Right.
So probably where this ulceration, and then that's where the ulcer-like projection occurred.
And it has quite a broad neck on the CT too, right?
Right, yeah, I'll pull that up again. And then the other interesting thing to note is that there isn't much in atherosclerotic plaque anywhere on the aorta.
Yeah.
Not much calcium. Yeah, and it's a broad neck, and it occurred over a few days.
One of the first cases I ever saw of intramural hematoma developed into a frank dissection in about 5 days. So I just think it's a form fruste of frank aortic dissection, where you just don't have a second defect distally to allow the blood to re-enter and therefore establish circulation. So it's a stagnant hematoma that's looking for a re-entry point that it never gets. Therefore,
Right.
you don't as a frank dissection. I think that when I looked at statistics for it, the prognosis for this is a long time ago. The prognosis for it was the same as the prognosis for aortic dissection in those same days. So I really think it's just a different presentation, a form fruste of a frank aortic dissection.
Yeah.
It's that's really interesting. One would like to think that there may have been an intimal defect right in the beginning, but simply too small to actually perceive, too small for the contrast medium to go through it from the aorta into the hematoma, but that the tiny hole didn't heal or enlarged over time, or was an area of weakness that eventually became a relatively big area of weakness, at least in that location.
Peter, can you go back to the original CT, the one that had that?
The original. So she initially. This was like a month and a half ago. She came in with this small intramural hematoma. So this one is the one managed medically, and this one actually looked like it almost essentially resolved on its own in 1 month.
Yeah, it's like the intimal defect improved, or like transiently healed and then opened back up, maybe.
Yeah, maybe it didn't completely heal.
Maybe. Yeah.
All right.
Yeah, that's very interesting how these things evolve.
Yeah. And one more. This one's a quick one. So this is just a coronary CTA. There's not much, just chest pain is the main relevant history here. But so let's take a look at her. There's a lot of plaque in her LAD, and that's the segment of interest, really, this mid-LAD region. So if we take a look at that on a multiplanar reformat, specifically this region right here, I've already zoomed into it. So this is a good example of a napkin ring sign. And trying to.
Sorry, what sign?
Napkin ring sign.
Napkin ring sign. Oh, I haven't heard that.
So this is basically a large, basically a plaque with a central necrotic core, and it has a thin fibroatheroma. And in this case, it's a lot. I'll take off these axes. You can see it better. So this on the right image, the cross-sectional image, the hyperdense, the high attenuation area in the bottom is actually contrast. Could be confused with contrast, but if you with calcium, excuse me. But if you look on the image here, you can see that calcium is higher density, and then this is actually contrast that's moving through there. And then this larger area here is a large plaque, and it's essentially a central necrotic core. So it's a high risk plaque, and presumably there's a thin fibrous cap here that could rupture. It's a high risk lesion, basically.
Cool. That is a nice example.
Yeah. Yeah. Very nice.
All
Thanks,
right.
guys. That's all I got.
All right. Anybody else have cases? We kind of got through them quickly today.
I have a question. Have you guys seen coronavirus that's not the novel coronavirus in the literature? Have you seen other coronavirus infections? Because I've got a couple of them.
I've
Here.
seen MERS, and when I saw some SARS when I was a fellow that was shown to me from Canada.
Well, there was an article one of the oncologists was talking about that examined some 44,000, I think, nasal swabs in people who had respiratory infections, and about some substantial percentage of them, like 20% or so, I'll try to get precise numbers, were actually coronaviruses. So it's a fairly common respiratory infection. And, one of the cases that we looked at today was a bronchiolitis pattern. I can show it next week. But coronaviruses are there, and they're, I've seen them before especially in our stem cell transplant population, because they get a lot of scrutiny. They get their noses swabbed all the time, and so we pick up these things. But it's actually fairly common to have these non-novel. We're calling them pedestrian coronavirus infections as opposed to novel. So, if anybody else has any, I can show at least one of them next week.
Yeah, I can show.
look and see.
I can show some MERS cases next week of it's a more severe one, but there's 7 identified coronaviruses that cause disease in humans, and as David was alluding to, 4 of them just cause in normal people a common cold, and they are fairly common. And then you have MERS, SARS, and then this novel one from Wuhan that causes severe lower respiratory tract infection.
And the 12th case is evidently a Wisconsin person. So have you seen that?
At our hospital, it was announced yesterday, but it was it was a mild case because the patient was discharged from the emergency department and is in quarantine at home.
Okay. And is there imaging on that case?
I don't know, but my presumption is, because none of us would know that it was that one, but our presumption was it was probably normal, which has been described even on CT. There was that one, there's that one series that was published in Radiology that had, I think there was one series that had, some patients have had normal CTs at least at presentation.
Yeah.
So,
well, there was just an article I was looking at yesterday that showed several serial chest radiographs in a person, and the chest radiograph, they kept calling it normal, but it was not normal even at the beginning, but it just kept getting worse and worse. It was mostly left mid-lung and lower lung, low-grade consolidation in one of these cases.
I mean, if you look at the reports of the CTs that have been published, they describe all these findings, but what it looks like is organizing pneumonia, and then some more severe cases look like diffuse alveolar damage. So it looks like an acute lung injury.
Yes. Yeah, the organizing pneumonia component was really very striking because you have these peripheral, subpleural ground glass blobs, and, the lung from the hilum going out to those things is fairly normal, and they're all once out those outer edges. That's got to be a reaction rather than the infection itself in the lung. So it really does look like organizing pneumonia.
Right. We have 2 patients here that were transferred. One of them, I've seen the radiographs. I don't think either has had a CT, nor will they close down a CT scanner to quarantine, to scan them. It just looked like a mid and lower lung, just multifocal consolidation, kind of looks like I don't know what the time course is, if we saw it, if it were organizing pneumonia at this point, or if it's just like a bronchopneumonia, but not intubated, not acute lung injury, ARDS at this point.
Yeah. What else is interesting is, unlike SARS and MERS, the fatality rate is much lower. SARS was like over 10%. This seems to be falling between the 3 and 4%, and MERS was much, much higher. So it's interesting, but you know, I went back and looked at the MERS and SARS papers, and it looks the same, and it's not surprising. It looks like most viral infections do that don't cause bronchiolitis, but typically cause acute lung injury.
Got it.
There was, if anyone's interested, a couple months ago, I listened to a book about the 1918 Spanish influenza. I'm trying to remember the name of it. It was really good though, but it was kind of putting it into context. Because like you're saying, Jeff, the mortality rate here is very low. And it's, you know, and of course the issue with that was that was more, you know, young, healthy patients with big cytokine storm, whereas this seems to be more older, more susceptible patients.
Right. Yeah, I'll be interested to see some of the more epidemiologic stuff that comes out of China, like, you know, pre-existing conditions and age and all that kind of stuff, because I don't think there's a lot on that right now.
Yeah, the book I read was called The Great Influenza. I think it's a good one for any thoracic imager. It talks a lot about some of the faulty science behind how they originally thought it was a bacteria and tried to prove it was a bacteria and not a viral illness.
You said The Great Influenza?
The Great Influenza, yeah. I just checked it out of our digital library.
Oh, that sounds interesting.
There's some misinformation circulating the last couple of weeks about that, saying that the majority of deaths from that were attributed to secondary bacterial infections. I've heard that from a couple of people now, and I think that just does not fit. There was a very good PBS thing about this. I think it was American Experience or something like that, to this Spanish flu business. And some of those people were healthy in the morning and they died in the afternoon. And that's much too fast for a bacterial infection. I think the cytokine storm business, I think, is a much more potent explanation. And, you know, that was brought up at the time of this PBS documentary too.
Cool.
Well, yeah, the other interesting thing is that the Spanish influenza, you know, is traced back to Fort Riley, Kansas, which is kind of interesting. That was the first case was attributed to, you know, was thought to arise in Kansas, and it was only when the U.S. got into World War that it really became a pandemic.
Wow.
So I'll check out that PBS special, David. Sounds very interesting too.
I wish I could direct you precisely to it.
I already found it. So yeah, the American Experience, Influenza 1918, streaming online.
Okay.
If we're finished, if you stop the recording, Jeff, I would like to show you the case that I told you about last night.